So, this is one of those things that if the patient's already suffering from pain, we don't want you to have to deal with the same phenomenon. So, the objectives of my talk is we're going to kind of decipher the underlying issues or talk about a pathway to do that when these men are in your office and to try to develop a standardized approach to evaluation. The more you make it cookbook, the easier it is to recall and it becomes just mindless. And we're going to highlight some key components of physician to patient communication, word selection, how to control the flow of things so you're not in there all day with people going back and forth with a story you've already gotten. And I'll give you some tips on avoiding pitfalls. And some of that could be the time suck. Some of it could be, trying to get you to pinpoint it or to pin it on something that was done previously. And then hopefully give you a headache-free algorithm to manage this in your own practice. So it's often been said that whatever your perception is your own reality, regardless if it's actual truth. There are several patient and provider profiles surrounding a chief complaint of genital pain. So when you see someone coming in, you might make assumptions about this patient or where they've been, and they think about you and like, oh, what this person's going to do for me. But you want to be careful with assumptions because if you just think they're coming in seeking a pain prescription, that might not be true. And thinking that it's all, so-called in their head or psychological in nature might also not be the case. So providers get anxious and they, try to get these people in and out of the clinic as quickly as possible. And when you do that, you might not actually listen to what they're trying to tell you. And if the patients feel dismissed, that might reflect in those surveys they send out after they leave your office, which is not necessarily a great thing for you either. So one of the things I say to my trainees or residents, fellows in the OR is, same way every time. And a lot of that just has to do with repetition to make things go smoothly, usually in an OR case, but the same is true in the clinic. And I think if you can, adopt those principles, it's a key to provider well-being. We teach a course every year at the AUA annual meeting, and a lot of it, used to be centered on the topic of burnout, but I think people are even burned out on that topic. But now what we've tried to do is to make it more about clinical efficiency. So in terms of the assessment, there's a lot of questionnaires that we use in urology. Sometimes they get filled out and never looked at again. Sometimes they just get uploaded into your Epic Note. Like Tom, I also like Epic. But I think for me, what I've found to be most useful in my practice is to develop my own questionnaires based on the information I like to assess from patients. Have that done before I get into the room really save me some time. So, and then to control the conversation with the balance of open and closed questions, because if you've seen these types of patients multiple times, if you go in and say, hey, how can I help you? They might just rattle on and you're trying to get into that conversation and before you know it, 20 minutes has gone by. So this would just be an example because they've already filled out something before I go in. And Mr. Smith, I'm Dr. T, and I'm glad to meet you today. I see you've been struggling with scrotal pain since a prior hernia repair. I'm hopeful I can help you with this. I see you've tried several treatments without success, and based on the symptoms you've checked off, there's some possibilities I'd like to discuss. Does this sound reasonable to you? So you're validating what they put in, letting them know you read everything, but then it's a yes or no question at the end, so hopefully you can keep things moving. So I do have an intake questionnaire for male genital pain. I will share this with you. But basically, I get some basic information about the timeline and then, what they think is causing it. Because, one of the things I've tried to get away from over the years in practice is trying to talk patients out of their notions rather than kind of guide them to some other possibilities. The nature of the pain itself and what might be aggravating it. Bowel and urinary function questions are pretty important in my practice. We'll talk a little bit about pelvic floor dysfunction as this presentation goes on, but the two are often related. And then orthopedic or neurologic history, because, I've published a paper with some former residents in the Gold Journal. There's a strong association between hip pathology and ipsilateral scrotal pain, especially labral tears. But, people with spinal pathology, prior spinal surgery, and, nerve-related issues and neuropathies can present with scrotal pain where everything else looks normal to you. So if somebody comes in and they say, I have pain when I ejaculate, a lot of times for me, if it's not something static like a urethral stricture, it can be like a dynamic obstruction in the form of pelvic floor dysfunction. If they say their pain's relieved in sleep, that might be a tip off to something more orthopedic from just moving around during the day. Hormonal deficiencies, we've looked at this before. It might not be cause and effect. It might just be an association. But we've published about the relationship between low levels of testosterone and B12 because if they supplement these patients, whether or not it's placebo effect, I don't know because it's not controlled, but they do seem to get better. Narcotics, narcotics we know can affect hormone levels as well. Poorly controlled diabetes can, wreak havoc on the entire body. So this is my questionnaire. We're not going to go through everything on there, but basically it's a front and back. They fill that out once whoever's rooming the patient knows why they're there. They go through basically a chief complaint guided process. It's the same thing if somebody comes in for something simple like a VAS consult. We have those digital light boards that you can get free in your office and upload with your own educational videos. So there's less perceived wait time while they're waiting for you to come in. But a lot of times it shortens the amount of physician to patient time dramatically. So the other thing I do in addition to getting information from them is I set expectations up front. So, I explain, I'm a surgeon. I'm not a chronic pain doctor, right? I don't manage chronic pain. The only time I write pain medications is for the 30 days after surgery. That's it. And so if they need something longer than that, then, I get them to the appropriate people. I will rule in and rule out different forms of surgical pathology, but I'll do my due diligence before I simply say, all right, let's now consider referral to pain management. And so I explained that I use a structured program for assessment and management, but that I personalize it for all patients. They want to know that you're looking at them, you're seeing them, and you're not just rubber stamping them. I actually show them the algorithm, right? They actually have that right there in a single piece of paper. And it kind of explains that same concept that I'm not a chronic pain professional, and sometimes I can't always tell you what it is, but I can also tell you what it's not. And sometimes that's valuable too. So what do I think is rarely the cause? When I see these patients, I think prostatitis is rarely the cause. We had a nice discussion, I think Fiona and I yesterday about, some of my opinions on prostatitis. I think it's been largely overused when providers are without answers, right? It's become a grab bag in some situations. That doesn't mean it never exists, but I think as soon as somebody comes in with pain, you say, oh, it's prostatitis. We talked a little bit about tetracyclines last night, but fluoroquinolones for multiple weeks now, you get those little pop-ups in Epic about the tendon risk. If the patient gets better, remember, that's not evidence that you made the right call, right? There's the rule of thirds. No matter what you do, third get better, third get worse, third stay the same. And these drugs have also been shown to have anti-inflammatory properties. And if they're getting good tissue penetration, where other drugs might not, and exerting anti-inflammatory properties, maybe there's something to that. But that still doesn't necessarily mean it was prostatitis the way we think about it. Now, varicocele, there's you'll see literature going back and forth about, somebody came in with pain, I did an ultrasound, they reported a varicocele. Yeah, maybe I couldn't see it, and I don't know if I felt it. Maybe I need to operate for that patient. That's not been my experience. And then you get the problem with incidental scrotal ultrasound findings, and now with everybody having access to their medical record, they want to know, what does this mean? This has got to sound really bad. Trace hydrocele, I need surgery for that. No, you don't. Epididymal cyst, oh, no, you don't. It's like 2 millimeters. And, fat-containing inguinal hernias, a lot of times you're wondering, what do I do with this, right? Especially if you can't perceive it on exam. So some often overlooked causes, again, as I mentioned earlier, pelvic floor dysfunction. And one of the big tip-offs is when guys say that they have pain with ejaculation. So we actually have a very busy practice in the upstairs part of our clinic for our pelvic floor physical therapists. Urethral stricture, I manage a lot of urethral stricture, so it's a lot of times it's in the back of my mind. But I see patients that have been kind of dragged out for a long time for issues with pain. And, you do a simple uroflow and you see this long plateau trace and you're like, oh, wait a second. Labral tear of the ipsilateral hip, as I mentioned. And so fortunately, I've got an orthopedic surgeon, Dr. Stubbs, who collaborates with me, and it's kind of a direct channel. Anytime I see these patients, I just copy him on my note. He gets them right in, knows what he wants to do and what he might try, whether it's, PT, injections, and so forth. Spinal pathology, I don't necessarily go ordering, lumbosacral or thoracolumbar MRIs, but if I think that that's a possibility, or if they have some history of radiculopathy, I will ask their primary care to do that, because the less tests I have to order mean the less results in my in-basket, in that little file at the top that I have to read through and potentially do something with. Pudendal neuralgia, I don't necessarily slap this label on a lot of people, but I think it's largely on the same spectrum with pelvic floor dysfunction. So at the initial visit, I'll do the standard history and physical, but I'll look for the obvious on scrotal exam. But for most of the patients coming in to see me, everything's entirely normal. A lot of times, too, they've already had an ultrasound that's normal. Flow PVR, I feel like flow PVR is almost like a handshake in my office. I mean, before I even see a patient, somebody might have done one, and maybe what I really wanted was a urine specimen. But you can get some information about whether or not you have this young person and you see this crazy peak, or you see, staccato pattern, to voiding, or that plateau tracing that might suggest something like a stricture. But, with people who have trouble relaxing their sphincter, you might see a similar pattern. So urinalysis labs, don't necessarily get all these in everybody, but we might do a hormone panel, might look at some of those markers, like I said to you before, B12, vitamin D. PSA really depends on the age. Basic labs like a CBC, CMP. I see a lot of men, because I run a men's health practice and we treat a lot of sexual medicine, who don't have primary care doctors. And you ask them why. I'm like, well, I'm only going to the doctor if I'm dying. Well, you came to see me today about this. Well, this is a lot like dying. And so, but I don't do a lot of non-specific labs like SED rates and CRP because I don't know what to do with those in these instances. So you want to treat the obvious, right? Obviously, some guy comes in something like that, you're going to have to get some bolt cutters. But if I find deficiencies on labs that fall into my window, if I was the one checking them, I may choose to supplement those or, ask their primary care doctor to do that. I got interested in B12 when I was a student working on a neurology rotation, and I saw a lot of patients in this guy, Dr. Joseph Adler's clinic, that sounded a lot like what I'd seen on my urology rotation: chronic pelvic pain, bladder issues. And B12 normal starts around 250, 260, somewhere like that, on most reference ranges, right? LabCorp and others. But if it was less than 400, he put people on this protocol, and so many of them got better. And again, was it a placebo effect? I don't know, but it certainly was pretty dramatic. So I've done that in my own practice, and I find that patients do notice a kick in energy. One of the things that we struggle with is the nonspecific nature for a lot of the symptoms that men come in seeking testosterone for. Okay, and it's water soluble; it can't overdose on B12. So for low T, we work up appropriately. Now for me, one of the things that I do in some of these patients, especially if they're on the edge, is I might consider clomiphene as initial management. Why? If I can get them up into the 400s and so forth, and their symptoms are unchanged, and they really don't think that's the reason, if I take them off it, they don't plummet, right? They kind of go back to their initial starting point. Whereas if you blunt the axis with testosterone, they'll plummet way down and have that withdrawal phenomenon for a while, and then they might just assume that it was helping them because they feel worse than when they were on it. Alpha blockers in some patients, but it's rarely a cure-all. We talked about some of the concerns with alpha blockers. Seth did a nice job on that yesterday. Bowel regimen when it's needed. We debate what normal bowel health even is these days. Is it truly a bowel movement daily? But basically, if people are straining and having pain and complications from that, it might be something to think about because it factors into these pelvic floor patients. So assessments to consider as far as imaging, again, scrotal ultrasound. Nearly everybody who comes in with scrotal pain is going to get one of these, but a lot of times it's been done before they reach my office. If I'm thinking about it, the story's good, it gets worse throughout the day, it's fine if I lay down at night, it's not bothering me, I might order the actual hip evaluation so I can get the answer and get them over to orthopedics. Sometimes insurance pushes back and wants a plain film, not always, but if you do that just so you can move forward to get the MRI, you might notice some changes in their bowels. Occasionally the MRI of their spine, but I'd like to defer that to the primary care or even the ortho sports medicine people. The pelvic floor PT evaluation can sometimes be diagnostic and therapeutic, and it's really been helpful for me in practice. And a lot of these patients, see enough improvement that they don't continue long-term follow-up with me. Alternative medicine, early on in my career, I'd see people coming in with all these supplements and bottles and things I'd never heard of, and it doesn't matter what you say when they can read your facial expression. You're going, oh my God. And so I'm not dismissive about this stuff. So if they're looking for something like that and they want to try it, I say, fine. If you want to try acupuncture, the person down the street, you want to try this? So a lot of the things that, Jesse was mentioning, he opened my eyes to some things, some data, and he made good arguments for a lot of things that, are in CAM or complementary and alternative medicine. As far as medical therapies and some of the pelvic floor patients, I will consider Valium suppositories if the pelvic floor physical therapist gets back to me and thinks there might be a role for that. I found oral baclofen, just starting with a dose in the late afternoon or evening, to be very helpful. I'm not a big believer in gabapentin or amitriptyline. Some of these drugs can certainly cause drowsiness, but I haven't seen them to be very effective in my practice. They're used a lot by other providers. Spermatic cord block, it's interesting. If you go down an algorithm and you think about, whether or not a denervation is a reasonable idea for this patient, I was always taught that they needed to have 50% or more improvement from a block, even if it's just temporary. But on certain occasions, you do a block, which is local anesthetic to the cord, and it's going to wear off in a matter of hours, and then the patient tells you the pain never came back. And I never really understood that. I've heard anesthesial people speculate that you broke the cycle of pain. I'm not sure if that's true, but so it can be, kind of guide you towards future management or no management. Pudendal nerve block. I don't do these in the office. I've got a partner who does at times. IR even offers this at our institution. Some people have talked about Botox into the cord. We actually got an IND through the FDA to study that years ago and had that funded by Allergan. Just failed to accrue because you couldn't reach the end for the number of men that were willing to take a chance at not getting the actual drug. Steroids have also been looked at. So as far as surgical options, like I said, data's mixed on treating varicoceles. Same thing with vasectomy reversal. There's some data that if a guy comes in, he's got post-vasectomy pain. If he gets reversal, pain gets better. I'm always hesitant to operate just from the indication of pain because sometimes all you get is more pain. Denervation, again, if you've gone down that algorithm of care and they respond very well to the block, it's something that you can consider, but you need to set realistic expectations. I tell them if you responded, in my hands, about 2/3 of the patients note improvement in pain with this procedure. So, orchiopexy, I don't see a lot of adults coming in where I truly think that they have intermittent torsion. I've seen those cases, though, where you can tell that the testicle is just pulling up from perhaps cremasteric contraction or something and gone and divided those fibers, and I've got an N less than 5, but all the patients were happy with the outcome. So, I suggest avoiding orchiectomy. I've rarely seen that to be helpful. I don't do this in practice, but I've seen people, want this. I tell them no, they go get it, and then they come back and say, yeah, I still have the pain. So as far as surgical options in other disciplines, have somebody address the hip pathology. So if it comes back positive for labral fraying, labral tear, get them into the hands of the appropriate people. If they have spinal pathology and they want to consider injections, RFA, surgery, again, the right people. Pudendal canal decompression, very popular on the West Coast. I think Parviz Hamid did a lot too with triple neurectomies. Address the recurrent hernia. So if they're a general surgery patient and they said, I had hernia surgery twice on this side, I've got this pain, it radiates down. I mean, that's not an area I'm going in to kind of, decipher all their mesh and so forth. Fortunately, I have a couple high volumes hernia surgeons at my center. So in conclusion, male genital pain doesn't have to cause you pain as well. Like one person in this equation with pain is enough. But a structured intake form and management algorithm, I think, are valuable, right? It's going to guide you through the process. It's like a computer program. If this, then this. It's essential to set the tone early and the expectations as well. Let them know what you're there to do, what you'll look into, and what you can offer. But then after that, where you'll guide them. And this protocol is well suited for both, physicians and for your APPs because, if you've made it cookbook in nature, it's easy to follow. And a lot of times it doesn't require, in-office procedures. Multidisciplinary management certainly makes matters easier. So if you have good collaborative care pathways with these other providers that I mentioned, it's a lot easier to get them through the door. So that's all I got on that. I think we're going to lead into some talks by our competitors, but with that, I thank you.